I have a clinic where most people come in here frustrated, patients saying, nobody knows what's wrong with me. I've tried all kinds of things. Nobody can figure it out. So normally when people come in and they have this hip pain, or they have this groin pain, or they have this whatever pain in this regions of the body, and they've tried everything, I'm thinking SI. I just need to get my hands on you. I've only had one patient, one in my entire career that I remember, that he could not lay on his side and he could not do ab and adduction on his side. And he's like, it's killing me, man. Hey everybody, what's up? Physical therapist Dr. Whelton coming to you live from just outside the Tampa Bay area. If you are new to following me, I have a clinic where most people come in here frustrated, patients saying, nobody knows what's wrong with me. I've tried all kinds of things. Nobody can figure it out type thing. And I learned to get exceptional results in that patient population. I've published papers. I have all my online courses showing you what I do in here. So you can go to my website, Whelton, wheltonmethods.com, and I have all my papers that I published in journals, and then I have my online courses. So I have my Rehab Results online course, which is my orthopedic protocols, which is what I use in here. Then I have my, I have my myofascial method, which is, I published a paper on it in a peer-reviewed journal about describing, pain points that reflexively shut off pain on different areas of the body. People call it the F-bomb method. People love it. And then I have my cervical radiculopathy sciatica course that works for me about 80% of the time with my patients, relieving radiculopathy. And then I also have my results-based, cash-based business, where I teach you how I get the results that I get here and open a cash-based business. And then I have my VIP Inner Circle. So I am actually teaching live for free right now. And you can join my VIP Inner Circle on my website, Whelton, wheltonmethods.com. And you can come on to these lives that I do, and you can ask questions, this Q&A, and I'm teaching live. My goal is to get us diagnostically up here and to be the go-to people for evaluations and treatments, especially for difficult cases, okay? So that's that. So today I am talking about a rather interesting eval. So I see the same thing all day long. I see most of my patients, like I said, I've seen all kinds of people. Nobody can figure it out. Then I see SI joint dysfunction, sacral torsion, sacral shear, low back pain that nobody can figure out. I published a paper on that, okay, how I evaluate and treat it. And like I said, I go much more in depth in my online Rehab Results course. So I see that all day long. I see rib head misalignments all day long. People with severe sharp pain in their mid-back, and it's a costovertebral misalignment usually. I see neck tension from stress. People with this neck pain and they're hypertonic and they lose their curve in their neck. And I see that. I see headaches. I see, other things, plantar fasciitis, chronic pain clinic. So most of my patients have 2 to 3 issues. So anyways, so this particular patient was an eval that threw me for a second. So normally when people come in and they have this hip pain, or they have this groin pain, or they have this whatever pain in this regions of the body, and they've tried everything, I'm thinking SI. I just need to get my hands on you, open up your SIs, and the referred pain pattern of it to see if it goes away, okay? So most of my patients have been scanned up the wazoo, and they either say it's a bulging disc, which is causing them like 9 out of 10 debilitating pain, which doesn't add up when it was SI, or you have a bone spur, and that doesn't make sense either, or they've been told they're making it up, and they refer to psychiatrist. I had a psychiatrist email me, said, I follow your SI stuff, I fix myself, and I started evaluating my psychiatric patients, and guess what I found? And like, yeah, I know. I hear it all the time. They're in psychiatric offices, and they get referred to psychiatrists for making it up, psychosomatic pain. when they had SI. Anyways, so this particular patient threw me initially. So he came in and he said that I have pain in my hip, right here, right? Hurts to touch. So I was like, oh, bursitis, I'm thinking, right? He said, I have been to the orthopedic, and the orthopedic injected it 4 times. Each time he injects it, it makes it better. But I can't get it to go away. I think he said he tried PT, but it hurts when I walk, he said, right? So I said, okay, well, in my head, I'm thinking, well, that sounds like bursitis, If it hurts to touch, then it's not SI. It sounds like bursitis or maybe even a tendonitis of the glute med. So anyways, I was like, do you have back pain? And he said, which you don't have to have back pain to have SI, referred pain symptoms of fun. So, but I said, do you have back pain? He said, yeah, it actually hurts right in here, and he had pain in here. Sometimes, okay? So I had him read my paper on my website. I had him do my evaluation method, okay? And as he extended back, my left thumb translated superiorly, okay? My right thumb inferiorly. They both should have translated inferiorly. So that told me he had an upslip, okay? So I was like, oh, well, he's got SI. And then I point on his greater trochanter, and I start pushing around on the wow. And I'm like, well, clearly it wasn't above it, like where the bursa is. It was more on the greater trochanter. So I was like, glute med tendonitis, And so anyways, I was like, so he definitely has SI, but he definitely hurts to touch, to palpate, and the shot worked temporarily, the steroid they injected in his hip. So, okay, well then he's got both, right? So anyways, so I take him out to the clinic from here, and I pull on his leg, read my paper, I take my online course, rehab results course, to realign his SI. I pull on his leg, okay, to realign the upslip. I lay him on his side, and I start gapping open the outflare that he had, okay? Because in my paper, I outline that SI joint dysfunction is caused by an upslip and or outflare, I propose, that I do all day long. I see the same thing all day long, and that's how I realign it. And so I pull on his leg and I gap it open, and I said, walk for me. And he said, no, I still feel it. So, but what I would have done was a functional SI eval, call it, where I walk with him like this, pushing medial on the ASIS, gapping open the outflare in the back to see if any referred pain would go away right here. But you're getting into the gait control theory of pain. You're pushing on their hip, which causes pain. So how do you know, right? So I took out an SI joint belt and I wrapped it around him. First, you have to get the upslip first. So I pulled on his leg. Otherwise, this won't work. And so I pull on his leg, and then I put the SI joint belt around him, okay, creating a gapping in the back here at the sacroiliac joint for the outflare. And I put it around him really, really tight. And I said, now walk for me. And he's like, yeah, no, that's gone. And I'm like, totally? And he's like, yeah, totally gone. And I'm like, wow, that's crazy. That doesn't even make sense, because yeah, obviously you can get hip pain from SI. I see it all the time. But the fact that he was tender to touch that's more like a localized issue. But yet all of his pain was gone when I opened up his SI joint. So I was like, yeah, no, because he was tender to touch, I still believe that he had a gluteus medius tendonitis at the insertion, but definitely SI. But if you do my SI protocol long enough, or like I do, and hear that bursitis and tendonitis is, I find that the glute med or greater troch actually published it. I republished it. Read my papers again. Go to my website to find them. I republished it and said that I propose that greater trochanter bursitis, okay, hip bursitis, greater troch, is actually caused by medius weakness. So most of my patients I see in here are tender to touch on just above their greater trochanter. But when I put them on my SI protocol, which involves side-lying abduction, then their SIs with my full SI protocol, but specifically that, then their SI stabilize and get put back into alignment, and then their bursitis goes away. So I had deduced over the years that I believed that that's what was causing trochanteric bursitis or glute med tendonitis was a weakness, because all the people that, if you have an upslip, you have a weak glute medius. That's what stabilizes the upslip back into alignment. So anyways, I just put them on my SI protocol anyways. I don't even worry about the bursitis, other than the fact that it's going to probably flare it up a little bit because you're strengthening, your glute med, and the bursa is right there. And you just got to warn them that they're going to be sore for a little bit. Because if you don't warn them, what I found in doing rehab 20 years now is if you do not warn people that it is a possibility, anything is a possibility in the rehab, and something happens, like they have increased pain, like when I do a rhomboid rehab, right? I tell them, your rhomboid is angry, and they get the pain right in here. I'm like, your rhomboid is not happy because you have a muscle imbalance. So we need to strengthen that. And when we strengthen that for 3 weeks, it's going to be more sore, but usually about 3 weeks, it starts to fade. And I make sure that I warn them about that, because if you do not warn them about that, then they get mad at you. Okay. And so what I do before every treatment is I tell them what could happen, because if you start to make people in more pain and more sore, then they blame you, they quit, and then they're off into the medical system, So I learned that the hard way over the course of 20 years of doing this, and getting blamed for things that I was like, yeah, but obviously it's sore, you're strengthening a muscle, but that was logical to me, but it wasn't to the patient, So it's just things like that. I always say when I teach business too, I say the words you use in your clinic will make or break you. And if you don't explain things a certain way or use certain words, then the wrong message gets conveyed, and the next thing you know, people aren't happy with you. So I have learned that you have to warn people. You have to warn people that if I tell my patients they're going to be sore for about 3 weeks, it shouldn't be pain in SI rehab. It shouldn't be pain, because a lot of them, they lay on their side. It hurts to lay on their side. They can't sleep, right? So because it's out of alignment, so it's shearing bone pain, shearing pain. So it hurts to lay on their side. That's a major complaint of SI. SI, sacral dysfunctions, is that I can't sit on certain surfaces, I can't roll over in bed, and it hurts to extend back, sometimes bend forward, and they can't lay on their side type thing. That is a typical presentation of SI. They have mechanical back pain. But when they lay on their side and they're doing their exercises, I make sure I tell them, just wiggle your hips usually forward and find a happy place, because if you wiggle it forward, on their side, they're opening the outflare, and a lot of times that gives them relief. Happy place meaning a place that it does not hurt to do the abduction and adduction exercises. I've only had one patient, one in my entire career that I remember, that he could not lay on his side, and he could not do ab and adduction on his side. And he's like, it's killing me, man. And we tried everything. Put your foot in, when he laid on his side, I would be like, put your foot in front, okay? No, it hurts. I can't lay on it. And then we'll move it up here. No, it hurts. Move it down here. No, it hurts. And then I'd be like, move it back here, but don't tilt your pelvis back so you strengthen your hip flexor. You want to strengthen your groin. No, it hurts. Normally that helps people when I do it that way. We tried everything. And I finally said to this guy, after weeks of trying to figure out a position that he can do abduction, adduction, and I said to him, look, I said, this is never going to get better if we don't strengthen these muscles to pull your pelvis back in from the upslip and outflip. I said, but I don't like doing this, but you may have to just stick it out, and just lay on there and just do the exercises. I don't like doing that. I cannot stand putting patients in pain, with the exception of a frozen shoulder or post-surgical, but to gain range of motion back. But I don't like putting patients in pain. It throws off my results timelines, okay? Just flares the person up. And this particular patient, I told him, we're gonna just have to do it, just tough it out and do it, which I couldn't stand to do. I cringed having to say that. And in 3 weeks, he could lay on his side because he was starting to stabilize the thing, you know? So anyways, that is really, really, really important. But this whole case with this guy that had hip pain to touch, you know, was actually really the majority of it was coming from his SI. He could walk after I realigned his SI, but yet he was tender to touch, and everybody was focusing on the hip because he was tender to touch. But I screened the SI, and when I screened the SI, boom, no pain. And I was like, whoa, man. So he had trochanteric bursitis, a little bit, insertional tendonitis of the glute med, and his SI joint dysfunction, but he had SI joint dysfunction that was causing the main source of hip pain, okay? So always screen the SI. I tell people any pain from lower thoracic into the foot or weakness, foot drop has been documented to, I put that in republished my paper and put that in there. And I've seen it before that people have documented in case studies that foot drop relieved with SI realignment. Foot drop, quad weakness, numbness, any symptom that you can imagine. Basically from here all the way into the foot and the testicular region, groin region, genital region. I have seen that too. I've talked about it in another video. That can be caused by SI. Craziest referred pain patterns started showing up when I started using that evaluation method, my SI evaluation method, and I started realigning SI after SI after SI, which is what I do all day long. And I'm like, you're kidding me. That's SI, you know? Like knee pain. I remember one guy sat right here, and he told me, I just had both of my knees operated on, scoped to fix a cartilage, but my knees are killing me. And, you know, my first question is, what did the surgeon say? You know, he said, you know, he fixed the cartilage, you know? And I'm like, you get back pain? Yeah. And I'm like, do you get back pain when you get knee pain? Yeah. Which doesn't have to be that way. You can't go off that line of questioning, but I wanted to hear it. And he said, yeah. And I was like, you got knee pain right now? Because you can't find out what's SI or not referred without the actual pain, you know? And he said, yeah. And I said, okay, let's go realign your SI. So they were out of alignment. I pulled in his leg, gapped open his ASIS, the L flare, and boom, his knee pain was gone, both of them. And I'm like, well, we just found out why you still have pain. You know, it was because that knee pain skipped the entire chart. No other symptoms, but occasional intermittent back pain, and his knees hurt. And he had torn cartilage, and he had surgery on him. And that was causing his pain because you just confirmed it. I didn't touch his knees. All I did was realign his SI joints. And when I did that, he had no knee pain anymore. So we would just stabilize it and fix that. So anyways, got a screen for this. Just put him on the protocol prophylactically. It's 4 exercises, my SI protocol. Just do it. From thoracic to the foot. People do these exercises at the gym anyways. You know, like if there's no contraindication to do these exercises, then just put him on the protocol. You know, even though you're treating the knee because you think he has patellofemoral syndrome, what's it hurt to just give him ab abduction, you know, lower trunk rotation and piriformis stretch? What's that hurt? I can't think of a scenario that would hurt unless there's some kind of surgical reason why they can't do it. You know, it's just, it covers you. It's like a CYA, you know, it just covers your butt that maybe this is SI and the person didn't have it on the initial evaluation. You know what I'm saying? Because this is the cause of so much suffering in this world that I have found. Anyways, that's that. Join my group. I am live now teaching online with live Q&A. The group is free and you can join my group, and I will see you there. Go to wheltonmethods.com, WHELTON methods.com. Go to become a VIP member on my website and join that group, and you can ask me questions. And then eventually we'll get people to bring their own patients in, and we can do case studies and we can all learn. And my goal is to get people up here diagnostically and treatment-wise. Okay? Peace. Love you all.